two questions. First, is it okay for transverse myelitis patients to get flu shots and tetanus shots? Because we've been heard conflicting things.
All right.
We're laughing because we talked about this extensively in the pediatric group yesterday, so that's why we're kind of laughing.
Who wants to go first? All right. I'll give the intro, and then I'm counting on each of you. We're going to go down the line. There's not a single person here who isn't making a comment. And Jim, you're in the audience. Chuck, you're both saying something. Nobody escapes. So it's actually a very serious issue. We're all laughing about it, but it's a serious issue. There are large concerns in the autoimmune world, whether it's transverse myelitis, multiple sclerosis, neuromyelitis optica, ADEM, about the role of vaccinations. Are vaccinations a risk for developing the disease, and are vaccinations a risk for exacerbating somebody who's already had it? There's no absolute answer. I will tell you what I tell my patients in clinic, and I have witnesses here who all made me swear to it yesterday. My answer is the overall data is very reassuring that vaccinations are safe. And the overall data, from my experience, is these actual infections, so flu, in my transverse myelitis, NMO, ADEM patients, is far worse, and the risk of that infection is far worse than the risk of the vaccine. Are vaccines 100% safe? No, there's no such thing in the world as 100% safe. Is there somebody on this planet who has had a post-vaccination immune-mediated illness? Well, it's a large planet. I can guarantee that's probably true. Do we have very reassuring data, so let's talk about flu vaccine, to say that people at high risk do not have exacerbations after flu shots? And the best model, I think, is let's take the group of people on the planet who have the highest risk of having an immune-mediated demyelinating event. So who is that? It's people with multiple sclerosis. We already know that their immune system loves to go into the brain and spinal cord. If left to its own devices, it'll do it over and over, twice on Sunday, and keep going. So what happens if you follow multiple sclerosis patients who've received the flu vaccine versus ones who haven't? And there have been several large-scale epidemiologic studies looking into this, and there hasn't been an increased risk of relapse after the flu shot versus not. And I'm specifically talking about the flu shot, killed virus. I have no data for the live flu miss, so I'm specifically talking about the flu shot. So when people ask me, I say, get the flu shot, because I don't want to see you in the hospital in flu. And I'll just make one last comment specifically about flu is, last year at Children's, we had several kids admitted with neurologic illnesses mediated by the flu virus. And so we're all worried about the brain and spinal cord. It's an equal opportunity offender in terms of the virus causing problems. And so my vote is vaccinate. I'm the first to admit that I don't know everything about it, but the data I've seen has said overwhelmingly it's safe. You're up next.
No, I completely agree. I think that's right. I mean, there's an epidemic of measles, true measles, because kids in California have not gotten vaccinated, and some of these are fatal. And I think vaccines are very safe and prevent diseases that otherwise cause big problems. And so I think in virtually everybody, vaccines are safe. I do take the point that, you know, in some cases, parents of a child who has had transverse myelitis recognize, for example, in a series of vaccines, something happening with each of the vaccines that suggests there may be a relationship. And in that case, in which, you know, there's something that looks really suggestive of a link, you have to be cautious. I mean, you know, you certainly wouldn't, in that very rare scenario, go back to the same vaccine. That's obvious. But there's no reason to think that then that type of reaction would apply to all the other vaccines that you would be offered. And so there are, you know, I think you have to take it case by case, but I think overall, in the vast majority of cases, you need to get the vaccines.
And can I just add one thing that Doug mentioned is very important in terms of not applying an experience with one vaccine to others. And just remember one thing about, because you asked about flu shot, every year the flu shot is different. So if you think you've had an issue from flu shot once, you're never going to see that vaccine again. The strain changes every single year, and so there is no such thing as two flu shots being the same.
So if you were serious about going down the line, I'll
I'm down. I'm not the. It's not just going to be the two of us here.
You know, I mean, I think those are brilliant responses in an effort to just add something to those brilliant responses, because I would agree with everything that they said, but to try to throw something else in there. There is no good data on this yet, but there is a lot of epidemiological data and animal data that suggests low vitamin D leads to overactivation of the immune system. So even in TM, and this is just brings up this issue again, which is if you have a 25 hydroxy vitamin D level below 30, you want to get that up. And that may be, at least theoretically, something that will make your immune system less reactive, less likely to get out of control. So that is something you can do in this day and age where we slather on SPF 1,000,000 and we never go out into the sun. We're finding this very high rates in MS certainly, but also in TM patients as well. So you know, if it's low, I'm not telling you anything you shouldn't do anyway, get it up, and we see low vitamin D levels in a lot of people with autoimmune diseases. So that's just an added benefit to maybe reassure you a little.
Yeah, so I strongly agree with what Ben, Doug, and Adam just said. The point I always try to make to my patients is that it's extremely important to vaccinate, especially in our kids and adults who have had TM, because you're at a much higher risk of developing complications later on if you really get, for example, the flu. And the other reason is I have seen kids die from infections that they were not supposed to get anymore. So in today's age, I mean, the vaccinations were developed in the past to kind of prevent us from devastating illnesses. And so with the push over the recent years, where people said, well, I don't want to get vaccinated because I'm afraid of certain potential complications, now we have seen basically kids that are not vaccinated who die of childhood diseases that kids died 100 years ago. Nobody should do this anymore today. So, and then the point that Doug made is I don't tell 100% of my patients to get vaccinated at once. If I have 2 patients in my clinic where with a pretty strong link, they had 2 flu vaccinations in a pretty good distance, and I got TM twice following these vaccinations. In those patients, I generally don't recommend repeating that type of vaccination. But then again, the other types of vaccinations that are not the flu vaccine or the triggering vaccine, I say go ahead and get those.
And I'll just make a comment on that, just because it is, and I think your data is worth discussing on this. One of the things I caution patients about post-vaccination is it's actually very common for me to see a slight reemergence of symptoms after vaccination. So somebody had transverse myelitis, numbness, tingling, weakness, they get their shot, and in the next 72 hours, some things are coming back. And we see this quite often in Dr. Froman's talk on the idea of Uthof's phenomenon and temperature regulation. There are a lot of things we do in our body where old symptoms can come back, and when we look for new inflammation, when I've looked for new inflammation in the spinal cord, it's very unusual for me to see it. So I warn my parents, things might get a little funny in the few days after because everyone's panicked that things are coming back. And I've done multiple MRIs just to reassure folks, but I've been on the lucky side. I haven't seen reemergence of inflammation yet. So.
And vaccinations are extremely safe. If you look in this room, everybody's very worried because everybody knows somebody with TM who may have had some sort of a link to some, especially in the kids, to some vaccination. And we can see this a lot in our group of therapists. We have about 50 therapists. They're all very young. They're all about getting kids. And everybody says, oh, no, I'm not going to get my child vaccinated because I think they're going to develop something bad. But it's basically just you see a very skewed population here. If you go out in the general, in the regular world, you will see that there's almost 0% risk of any serious side effects of vaccinations.
So I have 2 children, and you know, I'm much more afraid. My kids get flu shots every year because healthy kids die from the flu. So I get my kids flu shots every year, despite the fact that I see a skewed view of the world, and they've had all their immunizations, and so I think. But do I kind of, when they get it, yes, but I really think it's important.
In NMO, there are no ifs, no buts. You get the vaccine. Most of my patients will tell you that if they get an infection, they're likely to get another exacerbation after that. So it's just a much, much better idea to get the vaccine to prevent the flu, prevent pneumonias. And so in my clinic, everyone gets vaccinated.
For those of you who know me, it'll come as no surprise that I concur completely with what Ben and Michael say.
Is this being recorded? Is this?
Yes! You can play it back.
Yeah. Can we do some editing and we'll talk? Okay.
I agree with all of them. All my patients, I recommend the vaccination because I have seen patients with MS that have become very, very sick when they got the flu, and we know that we can prevent that. So I don't see that they should not. I think they should get the vaccine, and not even the regular, also H1N1 if it's available.
Yes, vaccine often. There's a great program. I can't remember whether it was Nova Frontline that did a nice program on vaccinations and their risks, because I think out in the community there's also some thought that it causes some other devastating neurologic diseases. But I think they did a really nice job on it. I think it's worth watching.
Yeah. So this is the difference between Dr. Courtney and I. She's watching this on Nova. Penn and Teller did a series on vaccinations and autism. So I saw the Penn and Teller series. I didn't see the Nova series. But I have to say Penn and Teller did an excellent job discussing vaccine safety, just for the alternative audience out there. But anyway.
I agree. That program is very, very good. So in the pediatric community, this is a huge issue for all neurological diseases. In particular, of course, I am also an epilepsy specialist, and I have some kids who literally have one foot in the grave who are a lot sicker than the children who have been here. So it's a huge issue. And of course, I also take care of the kids who have these infections. And, you know, my advice is always to vaccinate. There are a number of studies. The biggest group that's been studied and the biggest question has been the link of vaccine and autism, okay? And I know that everybody has seen the, you know, the press releases of everybody who say, oh gosh, vaccines cause autism. Well, there's no medical data for that at all. And in fact, there's the data now has been, studies are getting close to, if you get them in the aggregate, over 1 million children. So that's an impressive amount. Anyways, are there these special situations in which kids with demyelinating disease, do they have I seen decompensations? Yeah, oh yes, I mean, I've had patients that have been like that, and my advice in those patients, whether it's TM, whether it's epilepsy, is, you know, we got to think about that, or to actually spread the vaccinations out, okay, which is a common thing that we do. If parents are a little uneasy about vaccinations, we say, okay, let's give X now. In a month or two, let's give another one, etc. The idea being to spread out the activation of the immune system, just in case we're worried of some sort. So this is a very, very hot topic, and the pediatricians have been debating it, but the general consensus in the pediatric community is that the infectious diseases that your children might be at risk for getting is far worse than the exacerbation of the disease itself, so, or the possibility of recurrence.
But just to clarify a point that I think Greg is making is, take the vaccine separately, but you still want to adhere to the schedule for a particular vaccine. If it's 1 month, 2 months, and 12 months, something like that, you should stick with that schedule. But each individual vaccine can be given separate from, say, DTP and MMR and hepatitis don't all need to be given on the same day.
Yeah, that was my exact point. Yeah, you need to adhere to the schedule, but spreading them out sometimes can be somewhat helpful. But yes, they need to get all of them within a certain interval.
Chitra leaving? Bye, Chitra.
Bye, Chitra. Bye, Chitra.
So I think as far as my 2 cents as a research nurse, I think if you looked if you tallied all of the benefits and you matched that to the risks, I think that everybody would agree that you may not only be helping yourself as an individual, but the community at large. And then I also appreciate all the comments about informing patients about what to expect afterwards, because I do field a lot of comments about how patients think that if they don't feel well after their vaccine, that they shouldn't get any others in the future. And so I think the educational piece is really crucial.
Okay, so we're going to enter the lightning speed round of the session because we're in the last 15 minutes. So we're going to limit things to 1 question, and I'm going to limit answers as best as possible. So we'll start here in the back of the room.
My daughter has NMO, and I know NMO responds very well to plasma exchange. And is there, I know the Mayo says to do steroids first and then plasma exchange. Would there be any benefit to do them simultaneously?
That is essentially what we do at Hopkins. I'm particularly more aggressive than the Mayo. They like to give steroids for 5 days first and try to avoid the risk of plasma exchange, but I don't like to take that risk. I like to start the steroids in the emergency room and call the radiologist to put the line in, which typically takes a day or 2 anyway. I could always reverse the condition if they just pop right out of bed with a dose of 2 steroids, great, then we can cancel the plasma exchange. But generally, I go right into it if within a day or 2 they don't make an immediate turnaround. Now, kids are a little different. I know that there's a higher risk of plasma exchange in children, and so I take that more seriously. I maybe give them a longer course of steroids before I subject them to the risk. And I think kids also with NMO tend to respond better to steroids. That one 3-year-old I've had who's had 3 exacerbations, one of them by MRI you'd say, you know, he can't walk, and then after 1 day of steroids he was already running around the ward. So I guess it's also age dependent.
My question is it common for TM patients to have circulatory problems?
Certainly could have circulatory problems, especially if there's a paralysis where you can't walk. Then you're always worried about clots in the legs. There are also cases of myelitis associated with clots, so it was caused by a clot to begin with, and we certainly screen for that when a patient with myelitis comes in. We look for vascular problems and things like that.
So 3 years ago is when I came down with it at T2 level, but my toes and my feet and my hands, and it doesn't matter what position I'm in, they turn blue, and they've tested my legs and said I gotta forget what they called it, the pushback of the blood doesn't go fast.
We see this very commonly, and this is basically due to the injury in the spinal cord. As you lose innervation to your muscles, causing weakness, sometimes you lose innervation to the nerves that give you the sensation. You also lose innervation to the nerves around the blood vessels that kind of keep them tight or open them, so like you have in your legs. So everybody who is able-bodied has a pretty good regulation of these blood vessels, and the tiny ones in the skin, that if you lay down or stand up, the response is quite the same. In spinal cord injury patients, you see that bluish discoloration, the cold feeling, and which is very dependent on position. So I assume when you lay flat, this kind of goes back to its normal state. Otherwise, okay. But you're not alone. There are many people who have similar symptoms.
For somebody that's at risk of converting to MS from TM, so clinically isolated syndrome, what is anybody's take on the oral medication that's available just out recently?
Ben, you need to screen these questions a little bit better. You're not doing a good job out there.
So fingolimod, it's called Gilenya. It was approved by the FDA September 21st. It'll be available for prescribing by mid-October. It's a once-a-day pill for FDA approved for relapse and remitting multiple sclerosis. All of the studies that have been done have been in relapse and remitting multiple sclerosis. There is no labeled indication for clinically isolated syndrome. What I expect to see is it not being prescribed for clinically isolated syndrome up front. The reason being, we always like to get a little more safety data with these drugs. The frontline drugs for relapsing remitting multiple sclerosis and that have FDA labels for clinically isolated syndrome, the injectable therapies we've had on the market for anywhere from 12 to 20 years, and the safety data is really good. We're in the hundreds of thousands of people on these drugs, and we're not seeing strange infections or issues. And so I think what you're going to see for the next 2 years probably with people who are at risk of MS is probably still using the injectable therapies while we get better safety data. And if the safety data for Gilenya or any of the other oral medications that are going to come out looks good, I think you'll see a transition to them.
Jim, you want to comment on that?
I agree with everything that Ben said, but yeah, I think the two big unknowns, there were 5,000 patients in the combined studies for that drug. So we have a good feel for what the side effects are within that range. But what we don't know is if there's an extremely rare side effect that is, say, affects 1 in 1,000 or something. We're not going to pick that up until it's been on market for a while. The other thing that we don't really know is cost, and of course that will drive who we can prescribe it for, because the insurance companies may not cover it if it's very expensive.
My question is, after talking to some of the parents here that have smaller kids that have been diagnosed with TM, is there a protocol that the doctors have to meet on, say our son went in, he was totally and completely healthy, but he was basically paralyzed from the chest down, and we had to jump up and down before they would give us an MRI, and the MRI immediately showed the lesion, and to us, it's now proven that it's all about time. It's about getting the steroids immediately and getting that inflammation down, and it seems like it's just a lot of misdiagnosis, and when you have paralyzation in a healthy child, wouldn't you want to immediately do an MRI to show?
Greg?
Well, I'll tell you, in the acute situation, there's a lot of things that run through our mind, especially in the younger children. I don't know how old your child was, but there are, as I was saying before my other answer, there are a lot more common things that doctors go down their checklist on before they think about these sorts of things. You know, when I get called, obviously, I give them steroids and send them to the scanner for their scan of both the head and the spine, because I immediately recognize this syndrome, even if it's in a young child. But that's a pediatric neurologist who actually sits on the TM board, you know, and many other pediatric neurologists do understand that sort of sequence. But emergency room physicians and people like that may not necessarily understand those sequences, and so I think, you know, us getting better information about the protocols out and what you do in the acute situation, having the algorithms available to non-pediatric neurologists or pediatric neurologists who don't think about this commonly, it would be a good thing. But you know, in children, you always go down sort of a list of things that, you know, are much more common than a syndrome that's 1 in 100,000 or 1 in 200,000. Okay.
But I'll also share with you a story. I had a kid at Hopkins that I was trying to get an MRI on, and this, depending on the age, most kids have to be sedated to lay still in the MRI machine for 45 minutes, which means we need anesthesiology, and they may need to be intubated. It is kind of a big deal, and I had to jump up and down for hours to get anesthesiology to do this immediately. So, you know, I guess it's not that uncommon that there is a delay like this. It is not
uncommon because of the sedation issue in the hospital especially for an MRI of the head and the spine, which takes a fairly long time. And we actually had to, as our pediatric neurology group, we actually had to jump up and down to get the hospital to change their sedation policies to be able to get acute stroke in kids with acute spinal cord syndrome MRIs and sedated MRIs in a much more timely fashion. So the bottom line is that there are not, pediatric anesthesiologists are extremely rare doctors, and so it's very difficult sometimes to get them in the MRI suite.
So one thing that sort of came out of the work that Doug and Chitra did that hasn't been stated, just to add it in there, is if you have, and this sort of goes to what you were saying earlier, Louise, is if you have somebody who has weakness or strange sensory sensations, and then they have a post-void residual, which is after urinating, they can't evacuate their bladder, since that's mediated by the sacral S2 through S4, that's at the bottom of the spinal cord. I mean, as far as I'm concerned, if that's the case and someone missed it, then that's, you know, that's a huge mistake. So you can't sort of fake voiding and still having a full bladder. If you have a full bladder in someone who's got some strange sensory symptoms, and that's, I just think, plain and simple, that is a medical error to miss that and to not jump up and down and get that. So I think getting that word out.
I will point out that there are many causes of full bladders in kids that are not spinal
absolutely,
cord
but
disease.
in conjunction with paralysis or weakness and sensory symptoms, those in conjunction are going to tell you that you're really needing to look at the spinal cord. Wouldn't you agree?
I would agree with that. I was just saying in general, there are lots and lots of kids who have extremely dilated / retained urine that for a variety of other reasons besides TM can show up.
So, but just to make a point and to bring it back to your question, and that is, so I think everyone on the panel, I think everyone in the room would agree, early recognition, good thing. Early treatment, good thing. I think that's kind of universal, and pulling the trigger on an MRI to recognize it and doing it in a safe way, or treating first and then getting the MRI as long as it's appropriate. I think those are all good things. I just want to take your question, though, and this is what Maureen was talking about yesterday, and I'm going to put it on you. As a parent in a situation, or as a loved one, or as a patient in a situation where you do not feel your needs or concerns are being addressed, how do you handle it? Whether it's at first diagnosis or something that comes up later. And Maureen, this is what you were talking about yesterday. I don't know if you have any advice on how to communicate with doctors or nurses who aren't listening or aren't hearing what you're saying.
Well, the unfortunate part for you all is at that point, you all didn't have any idea what was going on, and so you couldn't have known what in the heck to do, and so that's horribly scary, and I can't imagine. Yeah. So how could you all possibly advise them what to do when you didn't know what was going on with Landon? I mean, I can't imagine. But certainly, you knew there was something going on, something wasn't right with him, and so I don't know what to tell you other than just that, like he said, jump up and down until something does get done. And
the poor resident that was there, God love him, he might not be a doctor anymore, but my husband back in the corner and said, "You're going to do this, you're not leaving this," and we got him in there. So,
yeah.
And we got a diagnosis 8 o'clock that next morning.
Yeah.
We had to have a meltdown in the hospital to do it.
Well, then you got it done, so that works. I mean, I can't give you advice because you did it, but.
Honestly, that is the best advice for any sort of medical therapy that you need for your special needs child. You got it. I mean, as I shared during my lecture, I'm a special needs parent as well. You got to be the advocate. You got to jump up and down.
You know, one thing that's also very important, I think, now for people who have diagnoses, when you go in, you know, you do want to go to, when you see a new doctor, you know, if you can come in and have a folder, you should be collecting a 3-ring binder that has all of the visits, you know, requests the records, requests the images, because now's the time. This is a chronic illness, and you know, the doctors are going to be able to give you much more useful information if you go to see a new consultant, if you have the information in an organized way. And when you prepare to go in for the visit, you want to have on your list, realize that doctor may not get down even to question number 5, but you sure want to know what your top 5 questions are to help guide and direct, and up front say, I've got these 5 questions, so that they can pace themselves, help the doctors to do the right thing and be good doctors. And that is partly in your control to get them to do the right thing, to prepare for that visit, any visit, going forward.
Can I change the subject for 1 second? Are you about to cut us off?
I was getting really close.
One more question I would like to have answered is, I know that this panel is very focused on physical treatment and the science, but as a parent of a child who's in that, you know, say 10 to 16 range, I'm always trying to understand the psychology and the things that he's facing on a day-to-day basis, going to school in a wheelchair, going to school with forearm crutches. And I'm very proud of the way Landon has handled himself. However, we do have behavioral issues, okay? And so I look at those and try to understand, is this just him, he's 12, you know? Or is this him overcompensating for something because of his condition? And so I have to, as a parent, and I think all of us as parents have got to, I mean, we want to encourage their spirit, right? And if they need to overcompensate for something, that may just be the way it is, right? So you've got to encourage them and not kill their spirit, but yet we can't have them, as he gets older and gets more freedom, going down some wrong paths because we haven't held him back in certain areas. So my question is are there resources available for parents like this? Is there like a set of best practices? Is there just any information that can help us as parents try to determine the best path to take?
So it's a really simple question as the last question. That should be 10 seconds to answer.
10 seconds. Well, I mean, first of all, you bring up the great point, which is that, you know, a lot of times the parents will come and talk to me, and I realize that this is just normal developmental milestones. Yeah, he's going to be, you know, worried about meeting other kids, and, you know, kids, you know, about 12, they're getting sort of vicious at times in their social circles and the like. But, you know, just as some keeping it sort of general, first of all, you know, you don't want to keep on with a failed solution, so you got to be willing to sort of keep changing and trying things. But I do find it very helpful. I mean, I often, you know, use Paula Lazzari and Cody Unser and people who, you know, have had TM. So talking to other people who have been there, done that, gone through it, and experienced what they've experienced. But it is a matter of balancing. It is also very important to realize that you do need to treat them, you know, in many ways like any other kid. You don't want to neglect the other children because they're also deserving of equal time and the like. And that, you know, they are going to get used to the idea that they're going to have to share parenting and the like, so don't forget that it's a balancing act. But I wish that there was one right answer. I don't think that there is. I think getting information from other people who have been there and done that. And then if there are behavioral issues, then, you know, getting a psychologist, getting somebody involved, getting assessed, is there depression setting in? Is there something that needs to be intervened? So, I mean, I know that many people that have different responses, that would be a first shot across the bow.
I don't know, Greg, in your experience, if you...
Well, I certainly have had all of these issues with my child, and I agree with everything Adam said. I think the most important thing that he actually said, besides going to physicians who understand what developmental milestones are appropriate and what's due to a neurological disease. The other thing Adam said that was extremely important, which I practice in my own family, and I ask my parents to do that, is to treat this kid like everybody else. Yes, it's important to connect with the kids in the TM community who have gone through things, and that's very important, and that's why I was thrilled to see a bunch of the kids here talking, and they all talked. But at the same time, you want to make sure that you know, his normal development continues.
Right. And I agree with treating him like everybody else. But specific example, he gets in trouble for trying to be funny in class. Okay, if he was a normal kid, I may bust his butt, you know, when he gets home, right? But he's not. Okay, so he can't maybe get recognition in other ways that he would have been able to get if he had just not had TM. So do I just, sometimes I feel like maybe I let that stuff slide because he's got to have his niche. And I'm not sure if that's right or wrong.
But I think in general, some of the things I'm hearing there is he has to have appropriate niches. They can't be inappropriate. One of the things, and I encourage you to talk to Paula about this, because one of the things, I mean, she and I have talked about in the past is we don't want to also buy into the label that just because he is different, that he lacks global abilities. Is he going to be on the football team this year? No, he's not. Is he going to excel in other things? Absolutely. Was was I going to play the violin? No, not at all. Was I going to excel in other things? Possibly, with a lot of help and other people around me. And it's the same. Yeah, exactly. It's the same. It's the same for him. It's just there are different things that give us abilities or not, and this is just going to be one of those things. So I try to encourage my parents not to separate it out, because he does. All the kids need borders and boundaries and all of those things. But so this is going to wrap up the question and answer session. I wanted to make sure it's been a long morning. I really want to thank our panel. So these guys have been here for 3+ days, hopefully giving everyone all the time they needed, and we really do appreciate it. I want to give a thanks again to the Transverse Myelitis Association, their support of the program. And then finally for you guys, you survived. It's kind of like boot camp in a way. You made it through the 3 days, and you really should give yourselves a round of applause.
And of course, a final thank you for Ben and his group who made this all possible and threw the party. So,
The really exciting thing is after a couple glasses of wine, Adam said he's doing this next year in Baltimore. Do you remember? I swear.
Good job, Adam.
Exactly. No, but really, we appreciate all of your attendance and your participation. Hopefully it's been a worthwhile program, and when the next one occurs, we'll be sure to let you know. But everyone, travel safe if you're heading home, and hope it was a worthwhile trip. Take care.